Medicine in 2015. He currently serves as the lead medical director and the physician director of quality of the Division of Hospital Medicine. He is one of the elected senators at the University of Florida Faculty Senate and has been serving in the Senate since 2019. He represents the Department of Medicine in the Faculty Council in the College of Medicine at UF. He's also the director of the Care One Clinic, which he will be speaking a little bit about today. His academic interests are around transitions of care, care for the vulnerable patient populations, and integrating care models in the inpatient and outpatient settings. He's an avid promoter of interprofessional education to integrate multidisciplinary approaches in patient care. On a more personal note, I met Dr. Lukose earlier this year at the Society of Hospital Medicine Annual Florida Summit, where he presented presumably a similar talk, where he discussed this Care One clinic. He's had some outstanding outcomes associated with the multi-visit patient. So I'm excited to present to you Dr. Lukose and his work with the multi-visit patient.
Thank you, Dr. Gupta. I will share my screen now. You guys can see? All right, perfect.
Yes, looks good.
All right, thank you all for having me here. So my topic today is social determinants of health, a Care One clinic perspective. So I'm going to talk about super utilizers, patients who are also called as multi-visit patients, how to identify and manage the main reasons for high utilization and the impact of these patients when we use an interprofessional approach through an integrated practice unit. I will be starting with the patient case. All the patient names have been changed for privacy. Then I will talk about the multi-visit patients, discuss the background and the processes we have at UF Health. Then we'll talk about the Care One Clinic and outcomes. So Pat is a middle-aged woman, lives around 20 miles from Gainesville, who calls 911 whenever she feels unwell. She has good insurance and has an assigned primary care physician. Over 1 year of 1 year period, she had around 65 ED visits and 12 admissions to UF Health. So after each ED visits, she goes to another local ED with different complaints, and we do not have the number on those. So her usual complaints during the visits include variety of symptoms, including abdominal pain, chest pain, nausea, vomiting, dizziness, intractable headaches, and so forth. So she was referred to Care One Clinic from the emergency department after she was identified as a super utilizer of the emergency department. After multiple no-shows to the appointments, she finally came to the clinic for evaluation. I will continue her story at a later time. So a limited number of patients, commonly termed super utilizers, account for the bulk of healthcare expenditures. Multiple criteria for identifying super utilizers exist, but there are no standard methodology available for determining which criteria should be used for a specific population. At UF Health, a super utilizer patient is flagged when there are 10 or more visits to the ED, or if they have 4 or more admissions in a 12-month period. So here are some examples of our frequent visitors. So here you can see Joe is a 56-year-old male with a history of coronary artery disease, renal transplant, hypertension, generalized anxiety disorder, who comes to the ED every time he feels a flutter in his chest, a chest discomfort, or when he gets a panic attack. So at that time, he do not call the primary care office or use any other resources, but just calls 911. Kathy, on the other hand, is a young sickle cell disease patient with chronic pain and opioid addictions. She comes to the ED frequently for pain management. She has an underlying major depressive disorder as well. She has an already established hematologist and a primary care physician, but she do not use any of the available resources, just come straight to the ED. Jim, where on the other hand, is an uninsured, has poorly controlled schizoaffective disorder and coronary artery disease. Whenever he gets a chest pain, he just comes to the ED straight. And whenever he comes to the ED, because of his history, he gets admitted for high-risk chest pains. Jill here has a history of severely uncontrolled COPD and substance abuse history. Every time she comes to the ED, she gets admitted because of her extensive wheezing on exam, even though that's kind of her baseline. So, is there a common thread among the frequent visitors? In the past, frequent visitors were characterized as uninsured, mentally ill substance abusers. But formal analysis have revealed that this population carries a significant burden of medical illness. Many are actually Medicaid patients. Still, a large proportion of these patients do indeed suffer from mental illness and substance abuse. So it's as high as 70% at our institution. So one common theme that has been anecdotally is childhood trauma. If you look at the examples from previous slide, all four have some sort of mental illness. So the past week was the Mental Illness Awareness Week, and the Mental Illness Awareness Month is May. So it is high time to raise the awareness of those living with mental or behavioral health issues and to help reduce the stigma that so many experience. Stigma is a barrier to access mental health care. Not only does mental illness cause pain, distress, and loss, but it can trigger a social reaction. People with mental illness have said that that stigma, how people judge them, is a barrier to a full life. Reducing that stigma encourages people to seek the help they need for what we know are treatable conditions, and which can result in significant improvement in individual and family lives. So rather than categorizing patients based on their medical or psychiatric comorbidities, we have found it more useful to assess patients by evaluating their individual barriers to care. So experiencing homelessness and poverty, lack of transportation, untreated depression, coronary artery disease with angina refractory to medical therapy, or chronic pain. All of these barriers that, when added together, exponentially lead to high rates of ED and hospitalization. Why have we decided to focus on the ED visits? So not only are these patients the costliest in our system, but studies have shown that frequent visitors have higher mortality and poor health outcomes. So with some investment of time and resources, we can improve the quality of care of these disenfranchised patients and possibly even reduce mortality. So here we have an astounding statistic that some of you may be familiar with. An analysis by the Agency of Healthcare Research and Quality shows that the sickest 5% of US patients account for overall half of US healthcare costs. And these numbers haven't changed much since 1970s. At UF Health, our frequent visitors represents 6% of the population we serve, but they account for 23% of ED visits and 20% of total costs, which includes ED and hospitalization costs together. Just 5% of Medicaid beneficiaries account for 54% of total Medicaid expenditures, and 1% of Medicaid beneficiaries account for 25% of total Medicaid expenditures. So it makes common sense to focus our attention on this 6%, and it shouldn't take much money, more money, but just shifting the way we spend the money. Here some interesting numbers from Community Care of North Carolina. It's a statewide medical home project showed that the per capita Medicaid costs increased slightly significantly with the addition of a mental health diagnosis, substance abuse diagnosis, and even further when the patient suffers from both. So here the patient with diabetes alone, the per capita cost was around $10,000. Adding mental health issue or substance abuse doubled the cost, and adding both tripled the cost to 36,000. So clearly helping these patients require a team approach, which is a fundamental aspect of all currently operating super utilizer programs like ours. Many of you might know Atul Gawande. He's a great writer. So in 2011, Atul Gawande wrote that in an article called Hotspotters that spearheaded the superutilizer movement. So he described the pioneering work of Jeff Brennan. He's a family physician in Camden, New Jersey, who, after carefully evaluating claims data, discovered that the vast majority of high cost frequent visitors came from a nursing home and a low income housing tower in Camden. So Dr. Brennan later went to each local emergency departments, seeking out these patients and later developing a home-based care team approach that reduced ED visits and costs by as much as 50%. So clearly, leaders in CMS have realized the potential for quality and cost improvements. Cindy Mann released a bulletin a few years ago that some of you may be familiar with, highlighting several programs that are participating in work through funding from CMMI and Robert Wood Johnson Foundation. It also provides an in-depth look at programs that are already operating successfully. February of 2013, the Center of Healthcare Strategies and National Governance Association, they partnered to hold the first Superutilizer Summit that brought together the leaders in the superutilizer movement, CMS, RWJF, private health plans, and so forth. So they outlined the common themes among the programs represented. Their exclusion criteria were patients with conditions related to pregnancy, malignancy, trauma, recent surgeries, dementia patients aged greater than 80. They were all uniformly excluded from the superutilizer program, as were the patients who declined to participate. So their care team approach was with a social worker, nurse, a community health worker who were really tenacious. So you see this slide, though program differs in their structure and mechanism of service delivered, most of them offers linkage to primary care, substance abuse, pain management, 24/7 access, frequent face-to-face encounter, housing, timely post-discharge follow-up, and so forth. So many healthcare system and agencies have since used more than one of these approaches to implement superutilizer programs. But there are no standard process which has emerged to determine which criteria might be the best match for a given population. Institutions may choose from a variety of tool-based standards or use their own definitions. However, using superutilizer criteria that are poorly aligned with the population being served can result in misallocation of resources and diminished effects of interventions. To be most effective, healthcare institutions must understand which criteria are available and most relevant to their specific patient populations. So this is an example. Maine has an elaborate program. So it shows how the care team supports an existing patient-centered medical home. You can see uh, that there are a lot of things that affect the patient. So the patient is the center for all the care that's provided. It is very comprehensive in Maine. So all of you know that social determinants of health, they are conditions in the environment where people are born, live, work, play, worship, functioning, and quality of life outcomes and risks. So social determinants of health can be grouped into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context. Social determinants of health have a major impact on people's health and well-being and quality of life. Some examples include safe housing, transportation, and neighborhoods, education, job opportunities and job security, income, access to nutritious food, racism, discrimination, and violence. Also language and literacy skills. About 1 in 10 people in the United States do not have health insurance. So people without insurance are less likely to have a primary care doctor, and they may not be able to afford healthcare services. and also the medications that they need. So when the health is not well taken care of, they get chronically ill, and the chances of them being a super utilizer become very high. So to summarize this section, we talked about how super utilizers or multi-visit patients are identified and criteria differ in different institutions. These patients are the costliest in our system, but studies have shown that frequent visitors have high mortality and poor health outcomes. Also, the details shows that all such programs have a multidiscipline approach, also called an integrated practice unit, which is necessary in taking care of these patients. So at UF Health, multi-visit patients consist of 12% of the total discharges and 41% of total readmissions. Multi-visit patients readmissions rates are as high as 49% compared to non-MVP patients. It's around 10%. So definitely they need our attention. So we have two major, very robust and active committees in our institution. One is Emergency Department Multi-Visit Patient and Inpatient Multi-Visit Patient Committee. So in the ED MVP committee, we look at the patients who are frequent visitors to the ED, and on the inpatient side, we look at the frequently admitted patients so that's at real time. The ED MVP is like retrospective, inpatient is at real time. So in every meeting, there is participation from several disciplines, not just including but not limited to RN health coaches, case managers, nurse managers, pharmacists, social workers, home health care agencies, community worker agencies, and county rescue operation representatives, and so forth. So we meet twice a month and discuss the top super utilizers in the list. Through the multidisciplinary approach, we produce the best care plan for these specific patients. One might think, why do we have two different committees? Aren't they the same? We thought the same too. So we, when we made a comparison between the ED and inpatient multi-visit patients, there were only 40% overlap, 14%, sorry, which shows that the problem for these two populations can be different. So now I'm going to talk about our method. So viewing the high utilization as a symptom is the first aspect of it, just like a chest pain or shortness of breath. Next step is to identify the etiology of the symptom, like we do differential diagnosis for chest pain and shortness of breath. So here the root cause is the driver of utilization. So once we identify the driver of utilization, we make a multidisciplinary approach to come up with the best way to handle this symptom for this specific patients. As we address the driver of utilization, we will slow down the cycle of utilization. But it's not easy as it sounds. We must work across the settings, agencies iteratively over time to achieve stability. So 4 years ago, we collaborated with Vizient for the initiation of the inpatient multi-visit patient committee. And this diagram shows the care pathway that we used. So awareness of the existence of multi-visit population is the key. When we pulled the data in the beginning, it was very eye-opening to see that we have more than 100 multi-visit patients admitted at UF Health at any given time. So to identify in real time, the MVP committee members gets a daily list of patients who are currently admitted. Assessing the driver of utilization is a bit of a challenge since these patients are scattered across 3 towers and the social workers do the initial driver of utilization assessment. Since the numbers of patients are very high, we are just currently focusing on two teaching teams. One is called Green Medicine, the other one is on Family Medicine Inpatient Service. So these are a few examples of driver of utilization and responses. So if we identify that mental health diagnosis is the driver, then the social work gets all the resources available for the patient, such as getting them established to the psychiatric clinic. But if they're uninsured, with other resources such as free night therapy, free counseling sessions, and so forth. So the only difference is that this has to happen in real time. So we choose only very few social workers so that they will get the chance to see the patient every time they get readmitted, or even can keep a phone line open for them to call even after discharge. It is also very important to have a warm relationship and establish trust with these patients in order to get to the core of their problem. Chronic unstable baseline is a major category for us. For example, if the patient has severe COPD, who's dependent on 3 liters oxygen at baseline and also has severe wheezing at all the time, comes to the ED, and if it's a new doctor or a provider who evaluates the patient, for sure she will be presented for admission, because every time a new person listens to her, it's extreme wheezing. To help these doctors and others in the care team, we create care coordination notes or best practice advisories in our electronic medical record system, and it guides the team how to take care of these patients if it is a new provider. We also get community services activated, like we have a few programs called Take Charge, and also we arrange home health care for these patients, so that if the patient experiences a change in their baseline, the medical professional can assess and then get in touch with the primary care doctor and get some guidance regarding what to do at home so that we can prevent an ED visit or an admission. Another major criteria are that we have seen are unaddressed goals of care. If we identify this as the problem, we contact the patient's primary care physician to see if they can initiate this conversation during the next clinical visit, or if the patient is currently admitted, to consult the palliative care team. So we reach out to the attending or the team who takes care of the patient with that request. So, like I said, engaging with the patient while in-house is a very important factor. This will help to establish a trusting relationship. It may take multiple visits to establish that trust with the patient. Addressing the patient's pressing priority is very important. Sometimes we have to involve patient's family or friends or whomever they identify as their healthcare surrogate. Refer does not apply for the MVPs. So if they need something, we arrange for it. They need definitive and timely linkage, like an in-person connection, a warm handoff, and maybe after discharge, like a timely contact within 48 hours or 3 days. So the multi-visit patients need a person, a navigator, a social worker, a team to help them. Developing a strong collaborative partnerships and processes with community health agencies are key in making sure that the patients get the appropriate care as well. So we always plan for the patients to come back for their return. What we do is create care plans, like I mentioned, or best practice advisories with which all of us are familiar with. I don't know if you guys have it, but we use Epic, and there's a lot of pop-up that happens for these MVPs. It can be it can cause some fatigue, but that's the only best way that we can address these issues at this point. For the previous patient example I gave, if a new doctor sees the patient care plan and identify that the patient's baseline is like severe wheezing and dependent on 3 liters of oxygen, it will be very easy to make a plan or educate a decision regarding the disposition of the patient from the ED. If not, the patient will stay in the hospital until the patient says, I am feeling fine and I can go home now. So creating care plan, it is very challenging since it involves input from at least 10 or 12 different disciplines. For example, we include appropriate specialists as well in this care coordination plan creation. If the patient has sickle cell disease, we involve one of the hematologists to participate in the meeting on that given day and discuss the case and get the input from them. Or if it's a COPD or anything related to the lungs, we get a pulmonologist for the meeting and discuss with them and with the whole team and come up with the care plan. So one thing is that all the plans they are focused on patient's health, and it has to be very brief convey the baseline of the patient, and whatever it is written have to be used only as a guide to take care of the patient, but not the absolute way to take care of the patient. So in the beginning of the inpatient MVP pilot, we interviewed around 50 patients and presented the results at the UF Quality Week poster session. So out of the 50 MVP patients, 30% of the patient's driver of utilization was chronic unstable baseline. So for the past 4 years, when we still do the analysis, that's the most common that we see. 17% were inadequate supports and services. 13% were third-party driven, where a family member or someone else makes the decision to send the patient to the ED. So to summarize this session, multi-visit patients are a real scenario at UF Health, and there are two robust committees working hard to help these patients, as well as those who takes care of these patients. At any given time, there are more than 100 MVPs in-house, and so we all will come across them one day or the other. The usual practice of medicine do not work for the MVPs. There have to be a multidiscipline approach to take care of them. Viewing their high utilization as a symptom is very important. Identifying the driver of utilization and getting the appropriate team involved to help address it can help the patient to manage their conditions in a very efficient way. So I would like to go back to this slide from the first session. So we talked about the multidiscipline approach for taking care of the high utilizers. So the question always comes up, why can these patients be cared in a patient-centered medical home? I think it's really depends on the funding and time. So if there's a separate high risk clinic or the ability for extended appointment times with adequate support from social worker, pharmacy, mental health services, it probably can be done. So for an academic center like UF Health with highly complex patients and a case mix index that has been rated 7th in the nation, I believe this is a good starting point. So ideally, we want our patients in a patient-centered medical home, but many of the patients are not just ready to be mainstreamed. So as you can see, there are many complex care management models. Now I want to talk about an ambulatory ICU and hospital discharge model clinic that we have in our institution since 2012. The Care One Clinic. So in 2012 at UF Health, we identified 2,485 patients for having more than 4 ED visits in a 6-month period, and a pilot study was initiated. An ambulatory ICU model was created with a physician, pharmacist, social worker, registered nurse, psychologist, and an addiction medicine specialist. So these were patients referred to Care One Clinic from the emergency department for intervention. And we looked at the number of ED visits 6 months prior to the Care One appointment and the number of visits 6 months after the Care One appointment. So the study showed us that the patients who were seen in the clinic, there has been a decrease in the ED visits by 4.5 visits, hospital admissions by 3, decrease in hospital days by 13 days. Another important factor was that mental illness was present in almost 93% of the patients and substance abuse diagnosis in 66% of the patients. So again, it showed an 11% decrease in ED visits, 25% in hospitalization, and decrease in hospital days by 23%. So our goal and mission is to reduce the overutilization of the ED by the patients, improve coordination of care and quality of care, and eventually transitioning them to a local primary care physician. So we function as a transition care clinic, not as a primary care clinic. So we serve two discrete populations. Primary target population is patients with more than 4 ED visits in 6 months. For these patients, our clinic acts as a safety net, trying to catch them before they get so sick that they need to go to the ED. The secondary population we serve are post-discharge patients who are medically very complex multi-visit patients. Our goal is to get them seen as soon as they get discharged, get them established with the appropriate subspecialty clinics, and eventually transition them to a local primary care physician. So for those patients, we serve as a bridge. So each patient is seen by a physician who is always a hospitalist, a pharmacist, a dentist, and a social worker. Recently, we have a mental health provider as well, which is on a different day of our clinic. So the clinic is part of the division of hospital medicine. Hence, we integrate this idea into our day-to-day practice. We have around 63 hospitalists in our division. We have a handful of hospitalists who love to work at the Caravan Clinic. So the dedication they have in taking care of these patients are remarkable. They are great educators both to the patients and to the students in the clinic. They know that the usual practice do not work and that these patients are not easy patients. So they have to spend a lot more time with the patients for understanding the core problems. And we are really lucky to have these amazing doctors with us. Some of you might know Dr. Southwick. He's a tenured professor with us. He once said, Caravan Clinic is a window into the soul of our healthcare system. And unfortunately, the system is not meeting the needs of many in our lower socioeconomic groups, which is very true. So pharmacists and pharmacy students, they play a significant role in doing medical reconciliation, educating the patients on medications, and finding errors in the medication list. So to give you an example, if one of the patients comes back with uncontrolled hypertension, the pharmacist will call the patient's pharmacy to ensure that the patient has picked up the prescription, check if the dates are appropriate, or was it last picked up like 6 months ago for a 1 month supply. If the patient has a history of substance abuse history, they may recommend the team to do a urine drug screen just to confirm that the patient is still sober. At every visit, we ask if the patient has brought their pill bottles or the glucometers to check if the patients are following the directions that's provided by us. They also recommend a pill box or alarms and use the teach back method to show how they take the medicines and if they are following all the directions that we are giving it to them. So we have around 13 ED visits per week at UF Health with dental issues when we combine all the satellite EDs together. So this has been a big problem over the past several years. So in 2019, we collaborated with the College of Dentistry and created a curriculum for dental students to rotate in the clinic. So we have a dentist and 2 dental students each day on clinic days, helping these patients with comprehensive oral cancer screening, education on oral basic hygiene, and with the limited grant that we secured, help the patient to get to the dental clinics for extraction and other procedures. Social worker. Um, so social worker is like a quarterback for our clinic, a very integral part. So our social worker, Tiffany, has extensive experience in patients with mental health illness, and she has put that skill in use whenever it is needed. She screens for social determinants of health and drivers of utilization for our patients. She's very good and very quick with establishing trust with our patients, and she's very resourceful. She's also a champion in patient health literacy and screens every patient for that. A majority of our patients have limited health literacy. She also visits Caravan patients whenever they get admitted to the hospital and make sure that they comes back to our post-discharge follow-up appointments. And that has made a big difference in the length of stay of these patients. Whenever she go talk to them, they trust her and they know that we are going to take care of them. And eventually we get discharged and follow up with our clinic. So we were struggling with getting proper mental health care for our patients since most of them, I would say 95% of them are uninsured and the community resources are very limited. So in September of 2021, we started a mental health clinic just staffed by this amazing mental health nurse practitioner, James Poole. So this clinic is only for the Careborn patients. Um, as you know, at least 70 to 80% of the patient has some sort of underlying untreated mental health issues. So all those patients are very excited about these opportunities, and we have a 95% show rate for this clinic, and the clinic is full schedule, and it's like 6 weeks out to have an appointment. So we also provide counseling sessions for our patients by the counselor program at UF. We have an intern who comes and rotates with us for 6 weeks at a time, who provides separate counseling sessions for these patients. So these are 4 common scenarios that we encounter in the clinic. The medically complex patient with limited health literacy is often the most challenging. For this patient, time spent in education and coordination of subspecialty visits is the main intervention. Another most common scenario we see is coordination of care. This is a good example for it. One of our patients, who is a 60-year-old male who did not have insurance, was getting admitted frequently for uncontrolled diabetes. Patient had poor vision, hence he was unable to administer the insulin properly, and hence he had uncontrolled diabetes. So normally there's a high chance that he would be lost to follow up, but he came to our clinic. So the Careborn physician identified this issue, arranged an ophthalmology appointment with the help of the social worker. He had cataract surgery. With the help of the pharmacist, he was able to achieve self-management of his diabetes, and since then, no ED visits. And social worker was also eventually able to enroll him in Medicaid. So you can see Careborn is one of the main resource for these 2 committees, and we also get patients referred from these committees, and we schedule them at their request. Careborn participates in both of these committees and is one of the major resources for all the disciplines in these committees. Okay, now let me show some data that we collected over the years. I'll be showing some data up to 2019, since 2020 data is skewed because of the COVID, just like most of our clinics. We are pulling the data for 21 and 22 in the next few months. So far we have enrolled around 2,900 patients, and we have had around 10,400 visits over the past 10 years. Here the graph shows the number of patient visits 6 months pre-Careborn enrollment in blue and 6 months post-Careborn enrollment in orange. As you can see, there is a significant decrease in visits after the patient was seen in the Careborn and after our intervention. These are some detailed analysis year by year and month by month. Here also we can see we prevented around 2,400 ED visits. Here we can see the total ED treat and release visit. So the prior slide showed ED visits and then which led to hospitalization. This is just the ED treat and release. We have shown around 1,200 emergency treat and release visit decrease over the past several years. Here you can see that the length of stay seems to be decreased almost by 1 full day in our patients, and I think that attributes a lot to the support from the social worker. So we facilitate early discharges for these complex patients from the ED and hospital with the clinic appointment scheduled. So one way we do that is we have an open spot every day for the ED to schedule directly the patient to the clinic. And we also approve to follow home health care orders for unfunded patients, as well as patients who do not have an established primary care physician for facilitating early discharges. As we know, unless there's a primary care physician who can agree to home health cares, we cannot safely discharge these patients. And we have volunteered to do that, and since then have shown significant change in the length of stay of these patients. And we have also have, like I said, same day scheduling options. from the ED. They can schedule on the same day. They can come straight from the ED to our clinic to address most of their issues. So like I said before, we serve as a transition clinic, but not as a primary care clinic. So once we have identified and addressed the main problems, our goal is to transition them to a local primary care clinic close to their homes. We call it as a graduation day. Social worker uses her vast resources to find the most affordable clinic for the patient and gets all the resources for the patient and get a full packet ready for the patient on their graduation day. The pharmacist, along with the physicians, come up with the best and the most affordable medication, which is very important for this patient um, to have all the follow-ups that they need. We provide them a detailed graduation checklist with all the follow-ups and resources. All the patients, even after graduation, they are allowed to call the clinic for assistance. We have had that, I think 40% of the patient that we graduate calls back. So we give them that option to call the social worker if they have troubles with navigating the health system. And this is our motto: engage, transform, and overcome. So like I said before, we have students from most of the professionals. A multidisciplinary approach is the best way to take care of these patients. And we see these patients individually. We sit together and discuss the patient care plan for the patient along with the students and address the patient's needs from all aspects. So incorporating the upcoming professional students in decision making for these complex patients have been very rewarding. We have medical students, internal medicine and family medicine residents, pharmacy students, dental students, and mental health counselor students. Also, we have social worker interns rotate through this clinic, and they all have a very great experience so far. So we provide an innovative environment for the student education. We emphasize teamwork, understanding other professions, roles and responsibilities, also respectful communication to optimize patient care. And we have seen that they have been a very integral part of our care coordination. You can see over the years we have had enormous increase in the number of students. With the COVID, we had to cut back, but since January 2022, we have revamped it and we have residents, pharmacy students, and med students restarted their clinic schedules. So some feedback from the students, always it's positive. Our goal is to incorporate the multidisciplinary approach in the upcoming professional students, like I said, in their education, so that when they go out and practice by themselves, they could easily use these interventions that they learn from the rotation in their practice as well. So our clinic is open Mondays and Thursdays, 8 to 5. Now we are in the process of expanding it to a few more days since our new patient slot is like 6 to 8 weeks out. Like I said, we have a doctor, social worker, dentist, pharmacist, and the rest of the students who see the patients. And we also have a mental health clinic, which is on Wednesday afternoons. So to summarize this session, multi-visit patients, also known as super-utilizer patients, needs a multidisciplinary approach in their management. This approach have shown to empower the patient and decrease the utilization of the ED and the hospital and relying more on their primary care doctor and community resources. Limited health literacy is a major issue for our patient population. So all instructions that we give, we make sure that it's all in the layman's terms, and we do a teach back method to make sure that they understand what we are giving them as a plan. So it points out clearly that the super utilizers are not the problem. The fragmented healthcare system is the problem that they are unable to navigate. So coming back to our patient case from the beginning, Miss Pat. So she had 65 ED visits in 12-month period. We realized that she was dismissed from her um, primary care clinic's office and several subspecialty clinics since she had multiple no-shows. Most of the time when we looked back, she was in the emergency department. To give more history, her medical history is significant for coronary artery disease with recurrent chest pain, most of the time non-cardiac, atrial fibrillation, superior vena cava syndrome on anticoagulation, gastroparesis, uncontrolled diabetes, multiple abdominal surgeries, and so forth. So we can see clearly she is medically very complex and has chronic unstable baseline. So our first intervention that we did was listen to her, spend time with her in the clinic by each individuals from all disciplines. We scheduled her to come to the clinic every week. Eventually, we gained her trust. She then started to open up. We came to realize that she has a severe underlying anxiety disorder. She was abused as a child. She was bullied in school. Never could keep a regular job. She was also in multiple abusive relationships. So it was really a heartbreaking story. And it was very hard for our students to hold back their tears when they listened to her story. So over time, her untreated mental illness got worse. Um, then she became very ill. Due to her mental health issues, she was unable to navigate and utilize her resources. So every time she gets anxious, she comes straight to the ED, calls 911. Whenever she comes to the ED, every time she gets here because of her complexity, ED does a CT scan or some sort of imaging. According to her, that makes her feel better. So most of the time, she was discharged from the ED after all the workup. And this cycle continued. So our team helped her realize that she has an underlying mental illness. Fortunately, we were able to establish her with the UF Psychiatric Clinic. But then again, she did not show up for the appointment. She was very anxious. We brought her back to a Care One clinic, gave her more reassurance. Um, the social worker talked to her prior primary care doctor's office manager regarding reestablishing back to the clinic. So eventually she was accepted back to the primary care office as well as to the subspecialty clinics. And several weeks and months later, she was eventually seen by the psychiatrist and her primary care physician and subspecialties. She showed significant improvement, and eventually we gradually graduated her. We still keep an eye on her through the emergency department multi-visit patient committees and inpatient MVP committees. We were able to reduce her ED visits from 65 to 45. Still a long way to go. So we all come across heartbreaking stories like this, but the happiness that we get helping these patients with unfortunate circumstances is very satisfying and rewarding. With that, I conclude my presentation. Thank you, everybody, for listening to me.
Thank you, Dr. Lukose. That was an outstanding discussion of the Care One Clinic. I think there are some questions. Dr. Zahn, you have your hand up.
Yes, can you hear me?
Yes.
Yes.
This lecture, which I wasn't sure I knew I would like, I absolutely love. So thank you very much. I'm an emergency department provider in town at many emergency departments, and we see the overusers, frequent flyers. And from the emergency department perspective, we don't know what to do with them. We see them over and over, EMS abusing, nowhere to go, prolonged ER visits, multiple over ordering of tests because of attorneys and the legal problems and the lack of knowing and the lack of compliance. So this is great, but as an ER physician, what do I do when I see this patient? Because most hospitals don't have social workers or case managers in the ER, and there's no way for me to get a patient to care. Most hospitals don't even have primary care or outpatient follow-ups available for the patients, or even bylaws that require patients to be seen. So
Yeah.
just any streamlined process that we can fix things on our end, because we identify these patients maybe before you might.
Yeah, it is very challenging, especially for the emergency department doctors. So the inpatient MVP committee, no, the ED MVP committee is chaired by an emergency doctor, physician. Um, so it is very challenging. So, like I said, identifying this problem and being comfortable with this, taking care of these patients is, I would say, that's the most important thing. Creating the care plan has significantly changed the way the even the new residents who comes to the ED in July, it has helped them to take care of these patients. Otherwise, they'll be scared to take care of these patients or discharged from the ED. With that care plan, they can talk to the attending and then be be really comfortable sending them out. So it has to be a team approach. I don't think one physician in the ED can make that decision because it's very complicated because of the lawsuit and all those complications that we have to face outside. So something like this, a team approach is really important. I would say social worker is or a case manager in the ED definitely is a big help. They are the only ones who can find the resources in the community. um, I think that's the only thing that we can do, a multidiscipline approach. um, yeah, it's really hard to set up all these things in short period of time, but
Right.
if you do identify, eventually we'll have to get something of this sort.
Thank you very much. Just acknowledging and identifying that there's a problem and somebody starting to work on it is half the battle. So thank you very much. Keep up the good work.
Absolutely, thank you.
Dr. Ledford also has his hand up.
Yes. That was an excellent presentation and really admirable the way you guys have set up this multidisciplinary integrated approach to reduce utilization in the emergency room. And it's clear that it's being successful. One of the questions I have, and I apologize if you said at the beginning, was how is all this funded? We are in a non-integrated system here in the sense that the hospital, the major teaching hospital, is not owned and operated by the university. And as such, it seems like most of these interventions that you're talking about, although good for patients, are clearly good for patients, are primarily financially benefiting the hospital as opposed to the healthcare system as a whole. And so can you tell me a little bit about how this is all funded?
Absolutely. That's a great question. Thank you, Dr. Ledford. So when we started the pilot, there was a grant that we applied to, and it was around $600,000 for a 3-year period, which was approved. That's how we started it. But then eventually that grant ran out and we had to reapply, which we did not get funded for. Um, so I would say, so since then the hospital has taken over. We were 5 days a week in the beginning, but as you can imagine, we are not a revenue generating clinic, so the cost was very high. So we were on the chopping board with the days. We only have 2 days now. So the data itself has shown that we were really, really useful. So we are tracking the data really robust. Every 6 months, we get a dashboard from the specialist showing that we are still sticking with our mission, showing a significant decrease in the ED visit, and it's consistent. The data itself is the only thing that has been keeping us this clinic alive. Over the past couple of years, it was really challenging with the COVID. Everybody switched to telemedicine with our patients. They don't have telephones. They don't have any way to communicate, and we struggled a lot. Um, so after that, with that COVID surge over, we had an insurge of patients, and the leadership acknowledges it. And now, with the help that we are providing as part of the committees, they want to expand our clinic for at least one more day extra so that we can get these patients on. It is a good question, but it's challenging. It's non-revenue generating. Grant funding would be ideal, but unless we keep up with this data, we cannot survive. This clinic cannot survive.
I had a question related to that also. You mentioned, the reduction in utilization for the ED visits and for inpatient stays, but have you been able to run like a cost analysis of running this Care One clinic 5 days a week versus the cost of the ED visits, since it's so interdisciplinary and have a lot of specialists there?
Very good question. Yes, we do. We track the number of ED visit which is decreased, and then we calculate the amount that the patient could have used. We do that analysis in our dashboard as well, and it shows, I would say, 5 to 6 million over the past several years. I think almost 8 years we saved around 5 to 6 million. But the thing is, there's no visible money. It's just showing that when we prevent, this much amount is prevented, amount is saved, and there's no actual, like I said, if you understand, there's no evidence for that. It's just retrospective data analysis.
Right.
That is one of the data point that we present, which the leadership is not that thrilled about, but they like the patient reduction in the visits.
Absolutely. And then how much does it cost? How much would it cost to run the Care One clinic over that same period of time?
So as of now, on top of it, I don't really remember, but it's around 300,000 for the overhead as of now for the past 3 months, and then the Department of Medicine takes over the rest of the overhead charges. So that's how it is funded. So the hospital funds the physicians, the salaries, but the Department of Medicine takes over the overhead charges. So probably around 300,000 to 400,000, I would say.
For
Not
3 months?
accurate.
Okay.
No, for the year, for the whole year.
Oh, okay, okay. Thank you so much.
Yep, absolutely.
Dr. Miller?
Thank you. Really fascinating presentation. Thank you so much. So there was this randomized controlled trial from 2020 about the doing similar interventions for patients that were super utilizers, and they didn't show a benefit in a control group compared to the intervention group because there were significant declines in utilization in both groups, both the usual care group and the sort of cared for group, the intervention group. And so I wonder, is this an issue that you guys are trying to deal with because you've showed really impressive decreases in utilization among the patients that are enrolled in this clinic, but are you thinking about, like, could you see those decreases even without these interventions that you're doing? I mean, how are you guys dealing with that sort of issue that's come up in the literature? And then do you think that there's anything different about the interventions that you guys are doing in this that are better than what has been tried in the past? Or are you dealing with a different population of patients, something like that?
Thank you. Good question. So when we did the analysis, there are, I would say, 3 tiers: super utilizer, and low super utilizers. So when we look back, whatever interventions that we did not help the top tier, the high super utilizers. There was no difference. Whatever we did didn't make any differences. The resources that we provided didn't make any differences at all. So those are the biggest challenge, especially for the emergency department physician. There's nothing we could do to make this better. But the second tier and the third tier, that's where we see the difference, where when there is a real issue that we could fix or we can show a big difference, that's the patients that we are really helping. With regards to the studies with the literature we understand that. So like I said, different population, it's different methods. It depends upon what is the highest issue in that given population, and resources, when we rearrange the resources for that specific population, that's the only thing that helps. So it is always challenging. The population issues, the needs changes, so we have to readjust to that. So again, the super high utilizers, we have not been able to make a big difference, but the second and third tier, that's our main focus at this point.
Interesting. Thank you.
So we're right past the 1 o'clock mark here. A really fantastic presentation, Dr. Lukose. Thank you so much. And thank you to the attendees for your engagement. Please claim your CME.
Thank you. Thank you, everybody.